Welcome. I'm Dr. Lindsay Berkson, and tonight we have a bonus of a colleague slash friend slash brother slash kindred spirit. We have a physician, Dr. Alan Gaby, who is renowned as one of the world's leading experts on nutrition and medicine. In fact, this book, Nutritional Medicine, is really his life's work. It's 1,550 pages approximately. And I have known Alan, we first met in, I say 1977, he says 1978, tomato, tomato. We both were students taking a rotation in integrative medicine with Dr. Jonathan Wright, and he thought we were a match made in heaven, and he fixed us up on a date, and that's a whole other story. And the long conclusion of that is we have remained lifelong friends. Dear friends that really love and respect each other. And when I was ill over 20 years ago with breast cancer, he sent me a card with 2 breasts drawn saying, I love these, let me help you stay well, let's detox together. So I went over to Washington and I lived with him for about 6 weeks. He was gathering the information. We would be taking saunas for part of the detox, and we would be surrounded by piles of literature. His and my life has been about sleuthing through piles of literature, connecting the dots, and really showing clinicians and practitioners and smart patients how they can really use nutrition that's based in science to take care of themselves. So we are honored tonight to have Dr. Alan Gaby, and he's going to be talking, since this is a redefining hormone course, on vitamin B6, zinc, and magnesium, some very new studies that most people don't know about, because those are the ones that we've already discussed that hormones lean on, and we're so excited. Thank you so much to be speaking with us from New Hampshire, right?
Thank you, Lindsay. Concord, New Hampshire.
And you went to med school at the University of Maryland. Your father was a surgeon that I totally adore. We've known each other through thick and thin. We maybe have been also thick and thin, but we're excited to have all that you have. I know the last time you gave a joint seminar with Dr. Jonathan Wright, you had to cut it off at 5,000 doctors. The room wouldn't hold any more than 5,000 doctors. People really listen and honor your lifelong sleuthing of information, and we are very fortunate to have you on. So please take it away.
Well, thanks, Lindsay. So when I was 23, I got an epiphany. You know, Einstein said epiphanies are God's way of remaining anonymous, or something like that. Anyway, I was given a life path, and it was to learn about nutritional therapies, what works, what doesn't work, what's hype, what's real, and to teach the medical community and the public about this. So I've been seeing patients, but even more so collecting articles, as you said, and I've collected probably 80, 90,000 articles. And out of that, I was able to write this enormous textbook. It was first published in 2011. That's the second edition that you're holding up there. And it's got 16,800 references. And they talk about the use of dietary modifications and nutritional supplements for the prevention and treatment of over 400 conditions. One of the things we've talked about many times is that skeptics say there's no evidence. There's no evidence base on this, but there's myriad studies. There are so many studies, it's ridiculous that we don't learn about this in medical school. Many of them are double-blind, placebo-controlled trials. I probably cited 3,000 or 4,000 of them in my book. There are others that are uncontrolled, and some are just case reports or anecdotes. But that's still worth looking at. If you had anecdotal evidence that a safe, inexpensive treatment could help you, would you choose that, or would you choose double-blind studies that say a very dangerous and expensive treatment might help you? I would probably try the first one first, and if it didn't work, then I'd go to the next one. So I cited all things that I thought were relevant, regardless of the level of evidence, and I did try to say, well, this is better documented than that. But many of the things I've tried in clinical practice, and I'm sure that you as well have tried, are at the lowest level of evidence. It's, you know, somebody tried something and said, I think it works. It's like, okay, let's try it. Yeah, it does work. One of my favorite stories is a report that came out in 1946. Some guy in England said that riboflavin can prevent migraines. It's like, okay, let's try it. So nobody tried it. Nobody read the letter probably. Anyway, 10 years later, another doctor published in the same journal, the British Medical Journal, the same thing. And he was unaware of the first person publishing this. So then another 30, 35 years went by, And somebody else came out in the 1990s and said the same thing. And then he followed it up with a double-blind placebo-controlled trial that said riboflavin can prevent migraines. And if you look in neurology textbooks today, you think you're going to find that there? No. So there is so much out there that's being ignored. And this is my life goal, is to try to, first off, convince the medical community to embrace this. But interestingly, the public is pulling the medical community along, because the public knows what's safe and what's not safe, and what's expensive and what's not. And an interesting sidelight is some of the medical skeptics in my community, when I practiced in Baltimore, they thought I was kind of weird. But when they or their family members got sick, guess who they came to consult? Me. Because
tell the story about the rabbi, right?
Well, that was the rabbi. The rabbi was terminally ill. He was a 79-year-old man. He had end-stage congestive heart failure, and he had gangrene, leading to severe circulation problems. He had gangrene of 6 toes. And the vascular surgeon wanted to amputate both legs above the knee, but the cardiologist said he's not going to live more than a month anyway. His ejection fraction, which is the percentage of the blood that you pump out with each heartbeat, was only 19%, which is barely compatible with survival. So he was going to live between 2 and 4 weeks, depending on whether or not he had his legs amputated. This was early in my career, but I had read that magnesium injections can produce dramatic improvements both in circulation and in congestive heart failure. So to make a long story shorter, I gave him injections once a week. And it ended up going on for years. Not only did he not die after a month, he started getting better. He gained muscle mass. His ejection fraction went up in 6 weeks to 36%. He lived 8 full years with this ongoing treatment. But if he went longer than 3 weeks without an injection, he would start to go out on us again.
How come so many doctors and nurses are down on magnesium injections, especially right after an adverse cardiac event?
Oh, I have to explain why other people think the way they do. The one thing I can tell you is that a very large, rapidly administered dose of intravenous magnesium can be very dangerous and even fatal. As a matter of fact, when we were giving injections, like a woman who's in preeclampsia or eclampsia, a pregnant woman, you give 5 grams of magnesium sulfate by rapid push. And that can be quite dangerous. The nurses wouldn't even give it. They made the doctor give it. They didn't want the liability. So that's what people know about magnesium. But
that's why it's given as a slow push.
A slow push and a lower dose, too.
Lower dose.
You give a larger dose, you give it over hours, not over minutes. But it's interesting about the heart attacks that you mentioned, giving IV magnesium for heart attacks. There are 8 double-blind studies, all of which showed statistically significant reductions in mortality in people who got intravenous magnesium at the first sign of a heart attack. The mortality reductions were as high as 70% in many of these studies.
But how do you get a doctor to do that? No one's going to do it.
Can't.
It's crazy.
The problem is there was this other study. Interestingly enough, it was called ISIS. The study was called ISIS. They didn't know about the modern ISIS, but it was the International Study of Infarct Survival, ISIS. Anyway, they enrolled, I think it was 56,000 people. And it was the largest study. All of the other studies combined didn't equal 56,000. And what they found is there was no benefit, and there was an increase in slowing of the heart to a dangerous level, and an increase in arrhythmias and breathing depression. But those are all the side effects of magnesium poisoning. And if you look at the dose they gave them significantly more than all of the other studies. They made them magnesium toxic. And the problem is, when you take one large study and you do it wrong, it doesn't supersede the other 8 studies. What they should have done is try to figure out why these other 8 studies worked and why this one with the very large dose didn't. But that's where it ended up. They say magnesium doesn't work.
It's crazy, because then you've got someone who has a loved one that goes through a heart attack, when the data that really shows that a low, slower dose would really improve their outcomes so unbelievably, but no one would know the details, the back copy that you just shared, that they used too high of a dose. And that's why your book is so clarifying, because you take a lot of that detailed information for the practitioner, for the any kind of doctor, and even for the smart patient, and you put it all in here so that you could read it. And you put a lot of your own personal comments over the years of using these with patients, and so it's very helpful that you share those kind of details. The only thing is, when you're in an emergency, it's really hard to get a physician to work with you like that unless you already have an established relationship, and most functional docs don't really have hospital privileges.
That's true. And one of my hopes is to get the hospital-based doctors to start doing this. There is one note of encouragement that came out recently. There's a journal called Chest, which is basically about pulmonary lung diseases. And there's a doctor from Norfolk, Virginia, conventional doc. He's written critical care chapters and books, very well respected. He had become aware of a study that said that intravenous vitamin C can save people's lives when they're in septic shock. Septic shock is a life-threatening illness. The mortality rate is 50% in the US, 60% in developing countries. It's a very serious thing. So he had 3 patients who were almost certain to die. And he figured, what am I going to do? So he tried this IV vitamin C, and all of them had rapid and dramatic recoveries. They ended up with no sequelae, no organ failure. It was just so amazing. So he's the head of the department there, the critical care department, and he began doing this as a protocol. All patients that come in with severe sepsis and septic shock get intravenous vitamin C.
How much vitamin C, and which critical care center is this, Alan?
This was Norfolk, I believe it's called Norfolk General Hospital. It's in the June issue of Chest, but I know it's in Norfolk, Virginia. And the doctor's name is, I believe, Marik, M-A-R-I-K. Anyway, he also gave them thiamine, vitamin B1, based on some other information, and he gave them hydrocortisone, which you probably talk about. Hydrocortisone by itself has never been shown to be useful for septic shock, but a lot of doctors use it, so he threw that in as well. The mortality rate the previous year, same types of patients, same intensive care unit, was 40-point-something%. The mortality rate after he instituted vitamin C was 8%. So it was almost an 80% reduction. And not only did they survive, but their blood pressure came up rapidly within an hour. These people have low blood pressure. That's the shock portion of septic shock. They have to give them these massive drugs, and often they don't work, and then they end up dying of low blood pressure. Every single one of them were able to get off of their blood pressure raising drugs very quickly, and none of them ended up with organ failure. It's just the most amazing thing. So, you figure that typically people don't embrace that because it wasn't a controlled trial. But intensive care docs know what happens to septic shock patients, and 50 different centers around the world are using this now. And every single one of them, I'm told, is getting about the same results.
What's the dosage of vitamin C in that?
He gave 1.5 grams 4 times a day, so 6 grams a day, which is not an enormous dose according to some docs that use IV vitamin C. But the reason he limited it is a high dose, but it's not an enormous dose. The reason he limited it is because a lot of these patients come in with kidney failure. And when you have kidney failure, you cannot excrete the vitamin C, and it gets converted to oxalate. Oxalate can actually deposit in the soft tissues, and it can cause very serious problems. So he wanted to take a middle ground between an effective dose and a dose which in theory had the potential to cause further problems. So he settled on 6 grams a day, and you can't beat those results.
Well, so how is it that you were sharing on the phone with me today that there's some brand new information about changing the levels of the recommended daily allowance for zinc? And we were going to focus on, you have a whole entire book on B6. And in this course, we chatted about how B6 affects the duration of signal of a ligand of a hormone, especially estrogen and cortisol, et cetera. So you have a whole book on how B6 versus our today's toxic environment is an issue. So we're looking forward to what you say with B6, magnesium, and zinc.
Okay, well, let's start off with zinc. Zinc is present in whole grains, which most people don't eat, and it's present in some other foods as well, like dairy products and meat. The refining of the grains, though, takes a massive amount out of our diet, and the average person does not achieve the recommended dietary allowance. We're about, on average, 20% below the RDA. But the funny thing is, back in the 1980s, the RDA was 15 milligrams a day. And then they lowered it. Nobody was getting 15 milligrams a day, and it's like, well, everybody looks healthy to me. Maybe the RDA is too high. Let's lower it. So they lowered it to around 11. And then, some people were getting the RDA, still not a lot of people. But recently, they turned that on its ear because they pointed out that the studies upon which the RDA was based used what we call semi-purified diets. They're partly elemental, but they have all the fiber taken out of them. And there's a chemical in fiber known as phytate, Phytate. Phytate blocks the absorption of zinc. So they calculated how much zinc is in a typical diet and what the percent absorption is. But they based the percent absorption on these semi-synthetic diets that they were feeding the experimental subjects, and nobody eats a diet like that. They eat regular diets that have phytate in them. So based on computer simulation of what the absorption should have been, they realized that the RDA should be, guess what, 15 milligrams a day. Just
Back where it started. It's interesting. The brain has more zinc than any other part of the body. The brain is run by hormones, and hormones can't deliver their signal without zinc. But so many people are going paleo today and avoiding grains and carbs completely. These people should take zinc supplementation, or where else might they get it?
Well, it depends what you're eating. If you're having dairy products and meats, you get a reasonably high amount. Also, nuts contain some zinc. So it is possible to get an adequate amount of zinc in your diet if you choose foods wisely. But if you're eating a lot of sugar and white flour and fat, nutrient-depleted foods, you're not going to get the RDA. So in general, most people, if I didn't know much about a person, I would assume that they're probably 5 or 10 milligrams short on zinc. So I usually recommend that people take a basic multivitamin, multimineral, and if it's got 10 or 15 milligrams of zinc in there, that's perfectly safe. It's after we get...
most of them only have like 2 or 3 or 4 milligrams. Very few of them have...
Some of them do. The ones in the health food store are much better. The ones in the drugstore are often low. But it's not just that they're low. It's that the form of zinc that they administer it in is sometimes not well absorbed. Zinc oxide, that's what you put on your face to prevent the sunburn. Zinc oxide is not well absorbed, but it is often used, particularly in the drugstore versions as opposed to the health food store versions. So you got to look not just how many milligrams of things are in your product, but what form it's in. So the kinds of zinc that are well absorbed include zinc citrate, which is widely used, zinc gluconate, zinc acetate, and zinc picolinate. Picolinate sounds like a funny word, but it's the salt of picolinic acid. And picolinic acid is actually a metabolite of tryptophan. The body produces picolinic acid, and there's some evidence that that is the naturally occurring zinc-binding, zinc-transporting molecule. And there's a rare genetic disease where people actually don't make picolinic acid. And for that reason, they can't absorb zinc. It's a severe skin disease known as acrodermatitis, meaning dermatitis of the hands, acrodermatitis enteropathica. They get diarrhea, they get immune failure, and it's a pretty serious problem. And it's a genetic disorder, and they discovered many years ago if you give a very large dose of zinc, that it corrects it. And then somebody came along around 1980 and said you can give a tiny dose of zinc picolinate, and it works just as well as the very large doses of the other form. So based on that, a lot of us began using zinc picolinate, which is quite effective, but I think other ones are too. The ones that I listed just don't use zinc oxide.
So is your first choice zinc picolinate, or is it more expensive? So now you might just say zinc citrate, any zinc is equal to any other zinc?
Well, most of them probably work about the same. If you have somebody who's got something weird going on that should respond to zinc and it doesn't, then I'm guessing maybe they have a metabolic defect and they're not making their picolinate, so I might try it then. But yeah, I think any of those are fine. I've used zinc citrate more often lately, based on some theoretical concerns, which probably are not going to end up being real, but the picolinate molecule in larger doses makes me a little nervous. I can tell you why, because in the test tube, it caused chromosomal damage to hamster ovary cells.
Oh, I don't like that. Now I've got a question. You know how you give magnesium on different carrier salts often to get a different type of reaction, like there's magnesium aspartate, magnesium threonate, and you use them for different reasons. Are there different reasons to use different carrier salts of zinc?
Well, maybe, but nothing that I've figured out to be sure. So your previous statement that most of them probably work similarly is probably correct. And I've used many different ones. If somebody comes in with a bottle of zinc gluconate, fine, just keep taking it.
So what are the dosages that you tend to recommend?
I'm sorry, what?
What are the dosages besides, if you were giving it for a specific problem like acne, or there's specific ways that you're giving zinc for immunity, what are the range of dosages that you recommend?
Yeah, I sometimes go up 30 milligrams 3 times a day for acne. And then after about 6 to 12 weeks, I'll cut it down to once a day. I always recommend, or almost always recommend, a copper supplement to go with that, because zinc interferes with the absorption of copper. And people on long-term high-dose zinc therapy can end up with some rather severe problems because of copper deficiency. Immune system failure, neurological damage, anemia, white blood cells becoming low. So that only happens with large doses for a long time, or if you start off very malnourished. Like if you have Crohn's disease or some serious malabsorption, and you start off on a high dose of zinc and you're already probably depleted in copper, that could be a problem. So in most cases, for the first 30 milligrams of zinc, I'll use 2 milligrams of copper. For 60 milligrams a day of zinc, I'll use 3 milligrams of copper. And for anything above that, I'll use either 3 or 4 milligrams per day of copper. And that should prevent copper deficiency. So let's see, what other conditions would I...
Well, you know, in the acne, the older studies used to combine zinc with vitamin B6, pyridoxine hydrochloride, and they said the action of the two combined acted like a natural antibiotic for the skin.
Oh, that one I haven't heard. Okay.
Okay.
So, yeah, well, B6 is very interesting too. But the zinc, aside from the level being low, there's the theoretical concern that environmental pollutants might be interfering with zinc. There is a particular pesticide, which is actually 6-chloropicolinic acid. So it's the chlorinated knockoff of picolinate. And one can only speculate, but I wouldn't be surprised if it turns out to be inhibiting the absorption of zinc. And maybe that's why we're seeing so many beneficial effects of zinc. Zinc can help you get rid of colds. As I mentioned, it helps treat acne. There are various smell and taste disorders. People with HIV, zinc supplements seem to help prevent infections in some cases. So there are a lot of things we can do. Now with B6, the book that I wrote, that was way back in 1984.
That's one of my favorite books ever. I love that book. I don't put it underneath my pillow, but it's really high on my list.
The funny thing about B6 that got me interested in writing this was I became aware of 2 lines of evidence. When you're a nerd and you go to the library all day, sometimes you make connections. And the connection that I made was that there are some new diseases like carpal tunnel syndrome. You've all heard of carpal tunnel syndrome. When that was described in 1959 for the first time by Dr. Phelan, you know, the Phelan sign where you do that with your fingers. They named it after him because he first described carpal tunnel syndrome. He gave this to a meeting of hand surgeons, and not one person in the room had ever seen it. That was in 1959. And then it became an epidemic. So that was one. Then there's ADHD, attention deficit, much more common than it used to be. Asthma is more common than it used to be. And premenstrual syndrome, more common than it used to be. And all of these respond, at least to some extent, to vitamin B6. So I became aware that there are either new diseases or diseases that are becoming more common, all of which respond to B6. And number 2, in the toxicology literature, I became aware of various chemicals in the environment, industry, agriculture, in the food supply to some extent, that inhibit the utilization of vitamin B6. So it was theoretical, but it was like, wow, the environment is messing our B6 metabolism up, and maybe that's explaining why people seem to be needing more. So I wrote the book about it, and it reviewed various conditions for which B6 is helpful. Around the same time, case reports came out that showed that people were actually damaging themselves with very large doses of B6. There was a neurotoxicity, sensory neuropathy. People would lose sensation in the stocking and glove distribution. And for that reason, people became quite afraid of vitamin B6, and they should at very high doses. If you're 200 milligrams a day or less, I have not seen any clear-cut reports of toxicity at those levels. So to be on the safe side, I tell people 100 milligrams, unless there's a really good reason you need to take more. For carpal tunnel syndrome, 50 milligrams once or twice a day usually does the job. For asthma, 50, 100 a day, so we can be on the safe side and still get the benefits of vitamin B6.
It's so interesting because this course is redefining hormones, because I show how so many hormone altering chemicals in our lives from the womb to the tomb and 24/7 from when we wake up in the morning to the evening are affecting receptor functionality, and that you can't look at a hormone anymore as a hormone because hormones are under attack and receptors aren't necessarily set to receive the hormone signal, which is what they're all about. And yet at the same time, what you're discussing is how our nutrients are also under attack.
Yeah, it's kind of scary. It takes me back to when we did that sauna thing. We sat in a low heat sauna for 3 hours every day, 130 degrees. And Dr. Crinian, the famed naturopath who developed this treatment, he'd come in and he'd smell our shirts and it says, "Smells like chlorinated pesticides to me." There's something
Remember
about
my shirt just ripped into shreds?
I do. Yeah, we washed your T-shirt in the washing machine, and it ended up with multiple holes in it. It was the craziest thing. And you said, "What kind of soap are you using?" I said, "What are you talking about? Your shirt is the only thing in this wash that had holes in it." But it was from all those chemicals that came out when you were sweating, because you lived in right above what was it?
Cleaners.
Cleaners, yeah.
An office that I worked in for a while was above a cleaners, and that was all the fluid. When we did this, I did it for a month and you did it for 2 weeks, and we did 3 hours of sauna and we did colonics, and we even tested our colonic, the fluid that came out of us, and we had competition as to who could hold the longest because we were separated by a curtain.
All right, enough of that.
Okay, enough of that. But that was all coming out. And then he tested our blood right after the detox, then 6 months and a year and a half. And we were still detoxing for a year and a half out because it was such a powerful detox.
Yeah. Well, after many years later, I bought an infrared sauna. And when I'd sit in there for 30 minutes, there would be the same smell, not as powerful. I describe it as a cross between Clorox bleach and Exit 15 on the New Jersey Turnpike. But after about 10 sessions, the smell would dissipate, which means at least the stuff that was closest to the surface was out. So based on that, based on just the whiff test, as you might say, it occurred to me that periodic infrared saunas is probably very good for your health.
Yeah, I think that detox has to move mainstream because we just can't get away from toxicants in today's environment, and they assault your nutrients, your vitamins, your minerals, your hormones. These are the basic signaling mechanisms of your life.
Absolutely. So the third of the triad, magnesium, I guess I left that for last, but there was a joke when I used to teach at the Bastyr School, the Naturopathic University. The going word was, if you don't know the answer to one of Gaby's questions on the exam, just write magnesium. You're likely to be correct. Because that was true. Magnesium is clearly my favorite nutrient. It's involved, as are the other ones.
Why is it your favorite nutrient?
Well, for one, almost everybody has suboptimal or deficient levels. Number two, there are so many benefits from increasing magnesium intake. I have seen so many people over the years where they couldn't sleep. They get muscle cramps. They get spasms. They were anxious. They were depressed. They were tired. They couldn't deal with life. They couldn't deal with stress. And I'd tell them to go get 400 milligrams of magnesium. Sometimes B vitamins with it, but not always. Sometimes. Anyway, it was just such an amazing shift just from that one thing. Didn't cure them, but they were so happy about that one little thing. And there was a guy that painted my house one year, about 10, 12 years ago, and he didn't show up for a week. And I said, "Well, where were you?" He said, "My wife has been in the hospital with asthma." So we started talking about it. And she'd had it for 20 years, off and on. She was on multiple drugs. She was often overdosed with the inhaler. Anyway, it's like, all right, what can I safely recommend to this woman that I haven't seen or examined or anything? And I looked at her meds, and she doesn't have kidney failure, so it was safe to recommend magnesium. So I told her to take 400. I told him to tell her to take 400 milligrams a day. So he comes back about a week later. She's like 50% better just from that. So I got bold then. It's like, okay, let's add a little B6 and a little vitamin C. Those are the three nutrients that have the best documentation and the best clinical efficacy against asthma. We didn't change the diet, even though diet is very important for asthma. Anyway, so after about 3 or 4 weeks total, he reports back. His wife is out throwing footballs, running long passes with her kids. She's doing stuff she hadn't been able to do for 20 years, and she's off of all of her medications. So most of that, I think, was from the magnesium. I've seen many people with recurrent migraines. You put them on magnesium, they get a lot less frequent or they stop. As I mentioned before, the rabbi guy, his intravenous magnesium was the most important thing for him. I've seen chronic depression resolve in some cases with either oral or intravenous magnesium. So if you look at the list of of symptoms of magnesium deficiency, and as I said, magnesium deficiency is epidemic in this country because of the refining of the food, because of the food choices, and because of the way we farm. We take the magnesium out of the soil. So if you look at the list of symptoms, it reads like the who's who of family practice. It's unbelievable. One more and then I'll stop here.
Wait, before you guys have a question though. Why is it so, besides it being insufficient in our lifestyle, it seems to me that magnesium is one of the glitches of God's design of the human body because it's so easy to lose it. When you're under stress, you lose magnesium in your urine and your sweat and your stools. It's not that easy to keep magnesium inside the cell intracellularly where it does its great deed. So if it's a cofactor for 1,000 different reactions or enzymatic reactions in the body, why is it so easy to lose under so many diverse circumstances?
Okay, so you're pointing out that magnesium depletion occurs as a response to stress, and I will add that magnesium deficiency makes the stress response worse. So it's a vicious cycle. Poor tolerance to stress and more magnesium depletion, and you can break that by supplementing. But your implication that God thinks we shouldn't have any stress, now that's a theological discussion, and I'm not sure about that. But it is true. It's kind of a tricky thing. Stress depletes magnesium. Magnesium depletion impairs your response to stress, and it just gets worse. And that's probably why so many people, just with that one intervention, can really tell a difference in a very fast period of time.
But one thing I just want to bring up is that what you're talking about are several hundred milligrams of elemental magnesium to really be helpful. But if you look at a lot of labels, they rarely state the amount of elemental magnesium. For example, a doctor's magnesium formula that was sold at a compounding pharmacy where they only carry doctor's lines that most of the people were using said it had 183 milligrams of magnesium. And I called up to find out because I wasn't getting the response I should, like you're talking about. After 2 hours on the phone with them, that product only had 18 milligrams of elemental magnesium in it. So a lot of the products that are out on the market have very low levels of elemental magnesium, and you want to purchase a product that says elemental magnesium, and you want it to be from 250 to 450 milligrams and take it once to several times a day. Otherwise, you can try magnesium replacement and not really be giving it the try that you thought you were.
Well, that's true. So, for example, magnesium glycinate is, I think it's about 20% magnesium and 80% glycinate. So if you say a gram of magnesium glycinate, and people think that means a gram of magnesium, but it doesn't. So right. You have to be real clear. And one thing to be aware of
is the labels aren't clear.
The labels, and that's a fault of the manufacturer. Sometimes it's kind of obvious because the pill is too small to have the amount of milligrams of either magnesium or calcium that it claims. So if it says, for example, 200 milligrams of magnesium as magnesium glycinate, then that's pretty clear. But if it says 200 milligrams magnesium glycinate, that's not clear at all. So you're absolutely right. You really need to know what you're getting, and you need 200 to 600 milligrams in most cases. I spread that out because most people cannot tolerate 600 milligrams at one time. They'll get diarrhea or other GI side effects. But the most common dosage that I use with people is 400 milligrams a day, hopefully spread into 2 different meals. And we just see a lot of good responses with that. You can also get magnesium in your diet, nuts and seeds, whole grains, a little bit in fruits and vegetables, meats, and dairy products have some as well.
So what's one of your most magnificent magnesium intervention tales from your patient tales? They're not Grimm's patient tales, they're wonderful patient tales.
Well, one of the things that intravenous magnesium does is it produces a rather pleasurable sensation, particularly in women. Now, I know you have a story about this, but I'm going to tell my own story. I was nonchalantly giving IV magnesium to a woman one time, and I was kind of staring out the window because you got to do it over 10 or 15 minutes or the blood pressure will drop. So I'm just sitting there, and all of a sudden she says, "Doctor, I didn't realize how much I like you."
Okay, I'm going to tell my little story now. Just really fast. So when we were both students in 1977 or 78, and we're taking the integrative rotation with Dr. Jonathan Wright, and he thought we were, oh my God, a match made in heaven. Look at these two people. So he put us together, and you said, and I can't eat Chinese food with MSG. And in that era, they all used MSG. Now you can order it without MSG. And you wanted to go have Chinese food, and I said, I don't want to have it because I react to the MSG. And you said, well, let's take you back to the clinic, and I'll give you an IV of magnesium. And
B6. The B6 was supposed to help, but we put magnesium with it because it makes it work better.
Right, and it makes you feel what you feel when the patient said, hey, doctor, I think I kind of like you. So it was really funny because I said, I don't know if I really want to date a guy who's telling me I got to go get an IV to have dinner with him, but I do think we're probably going to be best friends for life. Anyway, the rest is history. But what's some of your very, very best, because you have some amazing stories with, for example, with that patient with depression that had files that were like 8 pounds huge of, I think she'd had depression for years.
Well, I had a lot of different patients with depression, and, probably it's a little off the subject here, but I think since you talk about hormones, my most frequently successful treatment of depression is low-dose thyroid hormone in people who had normal blood tests for thyroid. And do you discuss that in your course?
We weren't talking that much about thyroid, so this is a great thing for you to discuss.
Okay, well, the definition of hypothyroidism, if you look back in the medical dictionary, it's a clinical syndrome that responds to thyroid hormone. It's pretty straightforward. It doesn't say anything about TSH or T4 or T3 or anything else. It's a clinical syndrome that responds to thyroid hormone. And they developed all these lab tests that correlate with the clinical syndrome that responds to thyroid hormone, but it turns out they're not always reliable. And there are a lot of people who have clinical evidence of hypothyroidism, delayed Achilles tendon reflexes. You look into Gowan and the Gowan physical diagnosis, it says it right there, hypothyroidism, delayed reflexes.
I always do that test. That test is more accurate than a lot of blood tests, but that's what of our era that doctors do it. Young doctors don't do that.
Well, we're teaching them, and some of them are doing it. Okay. And you got the puffy ankles, you got the puffiness under the eyes, you've got the coarse, dry skin, you've got general edema, and then you got 18 different symptoms: constipation, poor mentation, hair thinning out, depression, fatigue, cold extremities. You don't have to have them all, but a lot of people have many of them. And when the reflexes are slow, that's enough for me. Achilles reflex return being slow in combination with various symptoms, I'll give them a trial with low-dose thyroid hormone, and we adjust it based on response and adverse effects. And I would guess in 19 years of practice, I did a therapeutic trial with at least 1,200 patients. Almost all of them had normal lab tests. And we were very careful. We started slowly. We worked up carefully. We watched out for side effects. And if I had to look at my 50 best cases over the year, I would say at least 10 of them were thyroid hormone in people who were told by their conventional doctor that they did not have hypothyroidism. So depression, probably 50% of the patients that I have seen with depression had a significant improvement with thyroid hormone. Now, am I saying that 50% of the population of depressed people will respond? Actually, no, because this was a selected sample. If Mrs. Jones down the street responds to thyroid hormone, she's going to tell all the friends of hers who have the similar picture to come in and see me. So there is selection bias there. However, that's still a pretty darn high number.
So what kind of thyroid supplementation do you give? Because, I've really been struck that so many of the thyroid medications have talc in them, have dyes in them that have been linked to breast cancer. Johnson & Johnson just 2 weeks ago lost a case where a woman won $417 million because of the link that was established between talc and her ovarian cancer. So here you are on an empty stomach taking a pharmaceutical every single morning that could have these things. So did you make it compound compound, or how does someone avoid that? Or what are your thoughts on contaminant additives in thyroid replacement?
Well, in the years that I was in practice, excuse me, I used Armor Thyroid. It's a commonly known brand name. They reformulated their product 7 or 8 years ago, and it doesn't seem to work as well. I also used Thyroid, which is made by a small company, Thyroid, and it's the same raw material. It's desiccated thyroid. It's dehydrated, defatted pig thyroid gland, and it's a natural product. And that seems to work fine. So my first treatment is Thyroid now. Now, most conventional docs say that's crazy. And the reason they say is because it's not standardized, which is untrue. It is standardized. Back in 1980, there were some problems with some generic desiccated thyroid products, but never Armor Thyroid, and this Thyroid seems to be standardized. The other thing they say is that it contains T3, which is too much of a powerful, rapidly acting thing. But, you know, getting back to what God's plan was, if we weren't supposed to be having T3 go into our body, why does the human thyroid gland secrete it? For every 1 milligram of T3, there's about 9 milligrams of T4 secreted by the thyroid gland. So it seems that the body likes to put them out both at the same time. And what we find is that a substantial minority of people, about 30% of people, can tell a difference between thyroxine, commonly Synthroid is the most common brand. About 30% can tell a difference between the two. And of the ones that can tell a difference, 90% prefer desiccated thyroid, Thyroid, etc., and 10% prefer Synthroid. And I think it's because of the presence of this T3 hormone. The body's supposed to convert T4 to T3 efficiently, but if you got a body that's not working, you can't assume it's going to do anything efficiently. And the other thing is there's a third compound in natural thyroid known as diiodotyrosine. And everybody has assumed it's inert, that it's like a slough-off product and that it doesn't do anything. But I came across a study from 1914 that says that diiodotyrosine is the maturational hormone for tadpoles. So it does have some activity in biological systems. We also have some research from the 1940s that says diiodotyrosine can be used effectively to treat hyperthyroidism. So that raises the possibility that it is a modulator of the other thyroid hormones. And what Dr. Barnes, who clued us all into this using desiccated thyroid, what he wrote in his book was called Hypothyroidism, the Unsuspected Illness. He said that edema and dry skin respond better to desiccated thyroid than either T4 alone or the T4, T3 combination does. So there's probably a third substance in there that has some activity. And for that reason, I usually start with that.
You know, it's so frustrating for me because I'm on thyroid, and every time I've taken any kind of natural thyroid, I break out in hives, every single time. And I've done it over the years and retried it, and I still do that. So anyway, but I have a question. I would love, when you go through your book, remember you are the author of this book, Nutritional Medicine, which is 30 years of research. This man really has researched and put everything together for practitioners and smart patients about the science behind nutrition that most doctors say doesn't exist. It does, and it's in this book. A lot of studies that were really quite phenomenal in nutrition were older, because when pharmaceuticals took off, there's less studies on nutrition. And when nutrition was more the tools in the tool bag of a doctor, there were a lot more studies. So you and I myself cite a lot of these studies that are quite extraordinary. I could go on and on and on. Like I was at a conference with a functional gastroenterologist from the NIH, and I was talking to him. He was talking about gallbladder. And I said, do you know about the 1950 studies where they looked at the link of insufficient stomach acid, hypo or achlorhydria, with gallbladder? He didn't know anything about it. And he said, that's in 1950. I said, but science is science is science. So I want you to comment on that, because people have a misunderstanding about that, because that was the era of nutrition when a lot of great studies were done, and they still stand strong today.
Well, I did go over the whole riboflavin thing. It just illustrates that one of the reasons studies are so-called outdated is because nobody ever followed up on them. The human body has not mutated in those 50 years, at least not enough to change the results of those studies. There's another one there.
You haven't been on Match.com. Okay, sorry.
Now I forgot what I said. There was another study from the 50s. There's something called prickly heat. Miliaria is the medical name. And the same thing happened. Somebody wrote a study, said vitamin C helps that. 10 years later, somebody else came back, had no awareness that the other guy had written it, said the exact same thing. And then 10 years later, somebody else, again, with no awareness. So it just keeps going on and on and on. So if you go back, not all the stuff back there is legitimate. A lot of it turned out to be not. But some of it lay there gathering dust, and it is legitimate. And some of the things, the hydrochloric acid, low stomach acid thing is certainly important. And one of my favorite ones, again, since we're on the hormones, I'll bring this one up. You know, I've talked about desiccated thyroid. Back in the 30s, the Armour company, the ones that made Armour Thyroid, I think they made Armour hot dogs too, although they might have been a different company. Not sure. But they had a product called Desiccated Adrenal. And it contained the defatted, dehydrated adrenal cortex. And there was a doctor named Kemp back in the 30s who treated dozens of patients with nausea and vomiting of pregnancy. He based this on various theoretical points, and he gave them this Armour Adrenal, and 90% of them within 72 hours had a resolution of their nausea and vomiting of pregnancy. And then another doctor came around the same time, published the same results, and that died. And the only reason I ever came across that is because I went through the table of contents of all these journals all the way back to 1900. And it's like, wow, they were using desiccated adrenal for nausea and vomiting of pregnancy. Well, my wife happens to be a midwife. And when we were living in Pennsylvania, she was working with the Amish, and they have a lot of babies. So she had a lot of experience. And a lot of them got nausea, and she'd give them this desiccated adrenal gland, not Armour anymore because they don't make it, but she used a standard process product. And it was pretty much the way Kemp said it was. She had about 20, 25 patients, and they all pretty much responded. So you go back, I call it modernism chauvinists. If you say, well, that's outdated. Nope. It's not my fault that nobody followed it up. So,
do you remember I remember when I was in practice at the Center for Orthomolecular Medicine around the corner from Linus Pauling, we opened up our doors in 1981, and we used to give adrenal cortical extract shots. They were called
injections, yeah.
And it was helpful for this broad swath of serious issues, like things that people have today that they just can't get rid of. It was amazing. But the FDA put
the kibosh on it.
Yeah, they put the kibosh on it. Well, I have a question then, because, you know, I think it was the editor, the only woman editor of a prestigious journal, I think it was the New England Journal of Medicine. She went on to quit because she said there's so much junk science today that she couldn't maintain that position. And then she wrote a tell-all book. I tried to get her on my radio show, and she kindly answered me to say no, but she was so busy because everyone wants to talk to her. So since you've made your life sleuthing all this information, putting it like this, and lecturing to physicians, and having newsletters, and writing for the Townsend Letter like you do, can you explain what's going on with junk science and how the average doc and person should feel and know what's good and what's not? I know your book would be science that we could stand on, but could you address this issue, please?
Well, one of the things I tried to do in nutritional medicine is evaluate the studies and give my own conclusions on whether they're legitimate. Doctors and scientists like to get positive results just because it's sexier. And, you know, like, well, I tried that and it didn't work, but I'll publish it, but nobody will ever remember me because it didn't work. So I think there's an element of wanting it to work. And sometimes there's a conflict of interest. It's funded by a company that makes the product. So the first thing I always do when I see a study is who funded it. And you know, it's pretty clear whether there's a conflict of interest. And if there is, you got to look very carefully at the results, more carefully than usual. So,
but people won't realize how often there could be a conclusion that if you read the whole body of the article, the results in the body really don't back up the conclusions that the authors have. But you wouldn't know that unless you knew how to read it and analyze it.
Well, it's called spin. You've heard the term spin. I wrote an editorial 15, 20 years ago called Doctors and Spin Doctors. And they twist, they take the one part that they like. It's like the old joke, you race your friend and your friend beats you. And your other friend says, how'd you do? He says, well, he came in second. I came in second. He came in next to last because there are only two of it. Anyway, you spin it to make it look good. So, for example, let's say you have a primary outcome measure and you don't like the results of that one. So you don't mention it in the abstract. You mention the secondary outcome, which wasn't even primary. So people like to put the best face on one of their article, and you got to actually read the paper and try to analyze that. But in modern years, I think there's more actual research fraud. I think people are writing papers about research that they never even did. And it's very hard to prove, but I got my eye on some that's like, that's not possible. How could they have gotten this? And how did they do 18 double-blind studies in 6 months? It's like, so there's some of that going on. People need to publish to get grant money and to become famous, and they like to get positive results. So it's gotten pretty messy and pretty ugly, and I've gotten a little bit more jaded because in the old days you read stuff and it seemed much more straightforward, and they weren't trying to spin it like they are today.
So what does that leave if someone's getting into functional medicine and they're wanting to learn, you want to give something to your patients where they're going to go have the elbow grease to go to a store or get it online and then take it and spend that money? How do you get a sense? So I guess we should basically read your book. That's going to give us some guidance, but it's really difficult because even here, this famous editor quit the only woman ever to get an editorial position like that. And she quit because she felt like she could not stand behind how much junk science was corrupting. So
for most of my life, I've been an advocate of nutritional medicine. About 15 years ago, I began to move more towards the center because I became aware of just what you're talking about. People were hyping stuff up. So I kind of came into the middle. It's like, okay, here's what I think is truly evidence-based. Here's what's crap. And I do urge people to develop both the skill and take some time. If you're going to be recommending stuff, I think it's good to go actually read the study yourself. I know it takes more time, and a lot of people are busy.
So the NIH just gives you the abstract. What are ways that people can have access to the studies? What do you recommend?
Well, you can often email the author, and they will send you the PDF copy of it. So that's one way of getting it. Also, if you have access to a library, like if you're an alumnus of somewhere, they'll get it to you for free. So there are ways of getting it, but the worst case is you have to pay 30 or 40 bucks for an article, and that's probably not worth it. But yeah, it's very important to try to separate what's true from what's not.
Yeah, I sent you that article recently that I was so upset about, where they were taking a look at animals fed inorganic chicken, and the chicken are inorganic because they eat inorganic feed, and we are what we eat, and so are chickens. They are what they eat. And it turned out that rats consuming inorganic chicken over a 6-month period developed a hormonal pattern that was similar to polycystic ovarian syndrome, and they stopped producing progesterone, which is the friendly policing hormone of estrogen. So just as one of the themes of what we're saying tonight is that the external environment is assaulting our vitamins, our minerals, our hormones, and that's why we need to redefine nutrition and hormones. So whenever you work with a patient, you have to take a look at the bigger picture.
Absolutely, and get in there and sweat. That's probably one of the reasons exercise is beneficial, because you sweat toxins out of your fat tissue.
Right. I like to take a little extra niacin before I work out because it makes we started doing that on our detox. He had us take niacin and herbs, Dr. Krinian, before we did the exercise, before we went into the sauna. And that made us vasodilate, and the fat cells break open or lyse easier. So I decided to continue doing that prior to my exercise. I know you're biking now. So I take 300 milligrams of niacin. People always say, how is your skin so great? Well, I do it before my exercise so that I'll sweat more and get more detox bang for my buck while I'm exercising.
Well, that's good. That was actually L. Ron Hubbard, I think, didn't he found Scientology?
Yeah.
He wrote a book called Dianetics, and he developed the first detox program that had some similarities to
the fireman one. He did it before the fireman one in the 50s?
I think he was the first one to do it. And he had them take very large doses of niacin, right, and some vegetable oil before they sweat. And I think that's where that came from.
Interesting. Hard to believe that he was the one that did that, but very interesting dude. So we're going to be opening up soon to questions. So I want people to go to their boards and start asking some questions, because we've been very fortunate to have Dr. Gaby with us for an hour. Is there anything else that you want to say while people are typing out some questions?
Well, you just made me think of this study that came out in the New England Journal of Medicine a year or two ago. Niacinamide, which is the non-flushing form of vitamin B3, they found that it can reduce the development of skin cancer, non-melanoma skin cancer, which would be basal cell carcinoma and squamous cell carcinoma, by about 25%. 500 milligrams twice a day of niacinamide. These were people that either had a history of skin cancer or had actinic keratoses, which is a forerunner of skin cancer. And they followed them for a year, and it was highly statistically significant. So that was a pretty hot article.
You know, niacinamide is kind of like magnesium, where it's got such global conditions. 1,000 milligrams 3 times a day is great for osteoarthritis. It's also implicated. There's a new animal study out for glaucoma patients.
Right.
Again, it was 1,000 milligrams TID. So it's got all of these diverse different conditions that are helped. And you stated one time when we were chatting that niacinamide was the most alkaline nutrient that there was. And
well, I don't remember that. I said it was more alkaline than niacin.
No, I think you said it was one of the most alkaline supplements that there were. And
okay,
that's
well, maybe I did.
So
I reserve the right
why.
to forget whatever I wrote in my book.
It's hard, you know, when you put out as much information as you have and you've gone through as much information as you have. It's amazing that you contain all that you do, and you're still it's amazing you haven't expanded to assume the size of your home, but you haven't. You look, actually, to me, you'll always look exactly like you did when I first met you, which is gorgeous and wonderful. And we're lucky that you've been with us tonight. I think we have a question here. Let me look and see. So any ideas for why someone is nauseated after taking zinc lozenges?
Yeah, I have one idea, and that's because nausea is the most common side effect of zinc. And as far as what predicts whether they're going to get nauseated, I think just if things tend to make them nauseated, zinc and copper are each going to do that as well. Certainly, if you need to take zinc as a supplement with food, is much less likely to cause nausea than between meals. It is dose related, so if you're taking, what are these things, 23 milligrams, sometimes 13 milligrams of elemental zinc per lozenge, if you take fewer, then it will be less likely. There's one family doc who observed in his clinic that if you take a quarter of a zinc tablet and just put it in your cheek and let it sit there, it can take half hour or so to dissolve, and then you take another quarter of a zinc lozenge and do the same thing. So it's very low dose, continuous zinc lozenges as opposed to one lozenge every 2 hours. He said that his patients were universally fine by the next morning if they did it.
I thought some of the older doctors used to give zinc until you get nauseated, and then they'd back off from that dose, like some of the doctors would give magnesium replacement until you got loose stools and then back off from the dose, and they would use that as a saturation point. That's your point of saturation. But it's really when you have more zinc than your body can process, right?
Yeah.
So we have some more questions here. The same woman says, outside of intravenous vitamin C, what is the best form and dosage of vitamin C for therapeutic effects?
The RDA is like 75 milligrams a day for women, 90 for men. That actually will prevent severe manifestations of vitamin C deficiency, like bleeding gums and bruising and things like that. I generally recommend for a healthy person 200 to 500 milligrams a day as part of a preventive program. If you're treating a cold, it's highly variable from person to person, but typically 1,000 milligrams 4 times a day or more is useful for getting 30%. You reduce the duration of the cold by about 30%. For asthma, 1,000 milligrams maybe twice a day is useful for that. When you're not using massive doses, like more than 3 grams a day, it doesn't matter a whole lot what kind you use. Ascorbic acid seems to be slightly less well tolerated, more likely to cause a stomach ache or loose bowels when compared with the buffered forms of vitamin C, which would be sodium, ascorbate, or calcium. ascorbate. So when I'm using very large doses, I'll probably mix them because I don't want to get too much calcium or too much sodium. At the same time, I don't want to get too much acid from ascorbic acid. So I would go half and half, buffered and ascorbic acid. And if you take it with meals, as with other things, it's much less likely to cause GI side effects.
Okay, we have got a question here. Can you clarify again the elemental magnesium, how to know how much you are getting? Also, what would make a person sick from magnesium in an IV?
Well, I would have to hear more about what they mean by getting sick. But any reputable manufacturer should state on the label how much magnesium is in there. So if
they really don't, though. Even the doctor's lines don't. It's crazy. I went over because of this issue, and I looked at all the magnesiums that are People's Pharmacy, which is one of our highest level compounding. They have all doctor's lines, and there was only one product that stated 300 milligrams. And I went over to Whole Foods, and there wasn't anything that told me at Whole Foods. It's really difficult to assess. So what I've been using now is integrative therapeutics, because they say their tri-magnesium has 300 milligrams of magnesium in it, elemental magnesium, but it's not that easy.
Well, I would agree with, you get familiar with a few products, you know for sure what's in them. If you don't, you can call them up. Any reasonable company will have a technical support group, and if they don't know the answer, I wouldn't deal with them at all. But the companies that I've worked with over the years, there are a lot of companies that sell to doctors and present in pharmacies, and they know what they're doing. So you just have to find good companies. I'm not going to name any specific companies, but there are many of them out there that would deal with this issue, and they would deal with it in a respectable, proper way.
So there's another question. If a person gets really ill intestinally with IV vitamin C, do you know the reason? The person
they get sick, intestinal symptoms from IV vitamin C?
They've got cancer, so this IV treatment is an adjunctive treatment for this cancer patient.
Yeah, I don't know the reason for that. There was another question about something getting sick from IV magnesium.
Right.
Well, what I've seen as a side effect is the blood pressure drops. People get dizzy. They get very warm, sometimes uncomfortably warm, and sometimes they get just woozy. So it's all rate related. If those are the side effects, you either cut the dose or you give it much slower. There are a few people I've worked with over the years who just could not tolerate IV magnesium, and I don't know the reason, but it was definitely the minority. I gave probably 800 different people IV magnesium, and only about half a dozen we couldn't do it again.
Okay, there's a bunch, there's some questions here. So let me bring this up in another panel here. Pure Encapsulations has a product called magnesium glycinate. They only have 18 milligrams per capsule in that magnesium glycinate. I called them up and spent 2 hours on the phone with them, and I was recommending that until I discovered that. That's exactly the product, and I love Pure Encapsulation. I use a lot of their products, but now I make sure that all of my supplements don't have gelatin capsules, because I had Stephanie Seneff on my radio show, and she explained how when an animal eats inorganic feed, the glyphosate is concentrated in the gelatin capsules, and now I try with the minerals to really make sure that the label states the elemental amount in the minerals. And then she says, it is deposited does magnesium protect against calcium being deposited in the arteries? We know that vitamin K shuns calcium to the bone and not to the arteries. What does magnesium do with the deposition or protection of calcium as it goes through the body?
Well, the likelihood, it's based mainly on animal studies, but if you remove most of the magnesium from an animal's diet, they get calcification of the kidneys, they get calcification of the arteries. We know it's pretty clear that magnesium prevents atherosclerosis, both in animals and in humans. And calcification is not identical to, but it's closely related to atherosclerosis. So I guess the most important question is, how does it affect the funeral rate? And how does it affect the hospitalization rate? I mean, I'd rather be alive till 90 with calcium in my bones than be dead without calcium in my bones. So there's a massive amount of evidence that says suboptimal or inadequate magnesium intake is one of the major causes of cardiovascular disease. So yes, it probably does affect calcification, but it does many other things. It dilates blood vessels, it inhibits platelet aggregation, it improves endothelial function, it keeps heart rhythms more normal, and probably 3 or 4 other things that I can't think of right now.
You know what's so interesting is many of the wonderful benefits of magnesium replacement that you just listed off on your bullet list really overlap with hormone therapy for people who need it. Not everybody needs hormone therapy.
Yeah.
But people who are tested and insufficient, there's cardiovascular benefits from hormone therapy, and they really overlap with everything they said with magnesium. So caretaking your hormones along with adequate magnesium and zinc and B6 are really all together. That is a wonderful gift for any person to really help them stay healthier and younger longer.
Yeah. Well, that brings me up to another point. And I've been debating people for years about this so-called hypoadrenalism syndrome. My own opinion is that it's overdiagnosed. People say, oh, your adrenals are stressed. It's like, why don't you just say you're stressed? Why does it have to be your adrenals? There's 20 million parts of the body. And people say, okay, your adrenals are stressed, eat better, sleep better, get less stress. So yeah, these are all non-specific. Why do we call it adrenal? My point for bringing that up is that the symptoms that we attribute to hypoadrenalism are very, very similar to the symptoms of magnesium deficiency. And
if you can see how easy it is, people might even be taking a magnesium supplement, but not getting anywhere near the amount they really need because they're stressed.
Right.
And then they have that circle that's making things worse and worse, and the magnesium deficiency is getting worse and worse.
Yep. So Hans Selye discovered all this stuff about the adrenals and stress, and he developed what they called the general adaptation syndrome, response to stress, which had 3 components. One was adrenal hyperplasia. Another one was thymic involution, and the third was gastric ulceration. And in the 1960s, some doctors came up with evidence that there should be a 4th manifestation of the stress response, and that is magnesium wasting. So it's interesting because the stress syndrome causes magnesium wasting, as we said, and it leads to symptoms which overlap very much with adrenal insufficiency.
Okay, that's really good to know. Now, the same person says, what about magnesium threonate?
That I don't have any experience with, and I haven't seen any research on it, so whatever you told me would be new.
Life Extension has a number of articles out stating that it's the main form of magnesium that crosses the blood-brain barrier, and they recommend it a lot for different types of mentation and neurobehavioral issues, or avoiding brain drain, brain fog, dementia, etc.
Well, one of the things I do is I look through 600 medical journals, table of contents every month, and I've been doing this for many years, and I went all the way back to 1900. Many decades, as I said. And I also get these PubMed searches, magnesium and about 40 other nutrients, and every day they send me anything related either to adverse effects or therapeutic use of these individual minerals. And I've never seen anything come through on magnesium threonate. That's all I can say.
That's pretty interesting. I'd love to have you take a listen and a look, and then maybe I can get back to people to see if you actually put a search out on that, and I can let everybody know about that. We've got another question here. I understand that heart issues are increased with hypothyroidism. So can we add 400 milligrams of magnesium? Is there anything else that you would do as a proactive prevention in hypothyroid patients to protect their heart?
Well, the most important thing in hypothyroid patients is to get your thyroid level. Broda Barnes, who started this modern movement of treating people who were clinically but not laboratory hypothyroid, I call that sublaboratory hypothyroidism. He followed
I like that sublaboratory instead of subclinical hypothyroidism.
I have an article called Sublaboratory Hypothyroidism.
That's what you named it. So we're going to credit you with that, but I'm going to plagiarize the hell out of that. But I love that. Thank you so much. Okay.
Anyway, so Barnes had 7,200 patient years of observation. So, you know, like 720 times 10 years or whatever it was, 7,200 patient years of observation. And the incidence of cardiovascular disease in the patients that he had on thyroid hormone was about 95% lower than what would have been expected according to the Framingham study and other observational.
95% less, that's right. Statistically.
So correcting the hypothyroidism is crucial. With that said, there are many things we can do that have various levels of evidence regarding benefits. That would include avoiding trans fatty acids, avoiding sugar, getting regular exercise, taking magnesium supplements, taking vitamin C. So, you know, I have a chapter called atherosclerosis in the book. It's got 400 references. So rather than repeat that, I would just refer people to all the stuff that's been done that's as far as cardiac prevention.
Can you make a comment on some of the long ago early studies that have been very conflicting because it hasn't been supported by all the studies of linking women who are on thyroid replacement and a higher increased incidence of breast cancer?
Yeah, I do remember that. You know, there's this thing in observational studies that they call confounding by indication. It's like recently, just in the past week or two, people were sending me this article that said, I think if you take B vitamins, you have a higher incidence of lung cancer. People have been sending me that article. It's an observational study, and as you know, observational studies don't prove causation. So is it because they took the B vitamins that they had more lung cancer? Or is it because they felt horrible and that's why they took B vitamins, and feeling horrible predicts that you're going to get other diseases? So observational studies can be used to generate hypotheses, but they cannot be used to prove causation. So the question becomes then, these people that were hypothyroid, was it adequately corrected? And if it was not adequately corrected, did they have residual hypothyroidism, or did they overtreat them, which caused hyperthyroidism? So it's really almost impossible to prove. What you would have to do, and nobody's ever going to do this, is you take a bunch of hypothyroid people and you randomly assign half to get treated and half not to get treated. You'd lose your license if you did that. But that's the only way you can actually ever prove whether hypothyroidism, whether being on thyroid hormone is a risk factor.
Okay, boy, it's so interesting. I know that you've talked over the years a lot about observational trials. Can you let people know, because so often a study comes out with headlines and it's scary because scary headlines sell, but it's really observational, it's not causal. So can you share a little bit more how someone might know what that is and what exactly does that mean?
Well, they usually say right in the abstract that it's an observational study. They'll say it's either cross-sectional or prospective cohort. So in an observational study, you look at a behavior and you see what an outcome is. So people who do this have a higher incidence of that, or people who don't do this have a higher incidence of that. But that's just an association. There may be many reasons why people do something or why they don't do something. And you have to prove that A caused B rather than just A is associated with B. And the only way to do that in clinical trials is to do a randomization. You randomly assign half the people to get a treatment and the other half either to not get the treatment or to get a placebo. And many times, for example, the old studies on estrogen, on horse estrogen that is, found that women who took Premarin had less of just about every disease you can think of. But those were all observational studies, and there are many confounders. For one, women who took estrogen went to the doctor more often. They exercised more often. They had better cholesterol. They made more money. They had less stress in their life. They had all these things going for them, and they happened to be estrogen takers as well. And those confounders were the reasons that they did better. And when they actually did a randomized controlled trial, half the women were assigned to estrogen, half were assigned to placebo. They actually found either no difference in the disease or a higher incidence. There was more heart disease. There was more Alzheimer's.
That was in, are you talking about the Women's Health Initiative?
That was one of them. There were a bunch of different studies.
Yeah, but they were using really high dose. They were using older women who'd been off hormones for 10 years.
They were, but I'm just making the point that the observational studies showed different.
Yeah, okay.
I'm not saying you can't use estrogen. I'm saying that the way they were using it.
Good, because this is a course about
No, there's many things, great things you can do with hormones. But, you know, my old joke about horse estrogen is it came from the urine, which means even the horses didn't want it. But yeah, you got to use hormones bioidentically. You got to use the right doses. You got to know what you're doing. But all I was saying is that the observational studies on the use of horse estrogen completely contradicted the randomized controlled trials on the same treatment.
I just got to let you know that this is a person who gives courses sometimes 5 days long, and he usually pulls out his guitar. His favorite performer is Roy Orbison. He loves him. He's got him all over the place at his home, but he often does all kinds of songs on chemicals. I wish I would have asked you to bring your guitar and do that really funny song, kind of like Lear, you know, that there's strontium and galenium. Do you have your guitar around?
Give me 2 minutes, I'll go get it.
Okay, we're going to have you do that. So this is going to be great. We're going to get a song from Alan. Oh my God, I forgot to ask him that when we were putting this together, and it just came to me that he often does that with his lectures. So now we're going to benefit from it. And I see, Diane, you've got another question, so I'm going to ask him that when he comes back with his guitar. Is there any other?
Okay, here I am. Let's see.
So while you're getting your guitar out, there's one last question. How do you test people for hypothyroidism, and what causes so much of it? The question was, how do you test people for hypothyroidism, and what causes it?
I don't have my capo, so it's going to be low.
Okay.
This is a song, I kind of stole the idea from Tom Lehrer, who wrote The Elements, to a Gilbert and Sullivan tune.
Right,
so this
exactly.
is called the Medical School First Day.
Thank you. Thank you so much.
There's cytidine and thymidine, aspartic transcarbamylase, and also phenylalanine and tyrosine transaminase, cholesterol and bile salts, and lecithin and carnitine, methionine and histidine, asparagine and glutamine. There's androgen and estrogen, pregnenolone, progesterone. See, I got hormones in there. Insulin and glucagon and cortisol, aldosterone, more hormones, right? Aminolevulinic acid, uroporphyrinogen, and biliverdin, bilirubin, and profobolinogen. There's calcium, potassium, and sodium bicarbonate, and also chymotrypsin, phenylisothiocyanate, and cyanocobalamin, and thiamine, and niacin. Improve your contractility with epimerimycin.
Thank you so much. We are so lucky tonight. We have one last question before we really should be giving you clinking our glasses here. So Diane Calvo wants to know, how do you test people for hypothyroidism? What is your panel? And why is there why do we have so much rampant incidence of hypothyroidism?
Well, I think that a couple reasons why it's so high. I think that the environmental chemicals probably interfere with the thyroid hormone receptor. I think we're dealing with thyroid hormone resistance much more so than true hypothyroidism. And since it's not true hypothyroidism, the standard laboratory tests usually about 5 out of 6 times when I treat somebody with thyroid hormone, their TSH is normal, their T4 is normal, and their T3 is normal. I don't usually run the free levels, the free T3 and free T4, but when I do, those are usually normal too. Now, are they normal for that person? Probably not, but how do you know that? Because it's in the normal range. So what I do is I run that panel, T3, T4, TSH, and that's just to make sure that I'm not overlooking hyperthyroidism, because they look very similar sometimes. Hyper and hypo look similar. So if the TSH is not suppressed or the T4 is not at the top or above normal, and I think they're clinically hypothyroid, which is symptoms, physical exam, primarily Achilles reflex return, looking at the ankles, seeing if they're puffy, seeing if the skin is coarse and dry. So it's primarily history and physical. The lab tests is to rule out that you're doing something absolutely wrong, like treating them with thyroid when they're already hyper. And then sometimes I'll use the TSH to monitor. If the TSH goes slightly below normal, but clinically they're on the right dose, I usually keep them there. If the TSH is markedly suppressed, like 0.08 or 0.03, then I get too nervous and I'll cut their dose down. I always use a bone-building formula because there's evidence that over-treatment with thyroid hormone can thin the bones. I have not seen any evidence out of any of those 1,200 patients that they had accelerated bone loss that could not be explained by something else. I developed this product with Jonathan Wright about 20-some years ago called OsteoPrime. And the most recent incarnation is called OsteoPrime Ultra. So that's the integrative therapeutics company that you mentioned before, Lindsay. And so I always gave people that along with the thyroid hormone just in case there was a little bit of over-treatment. But it's clinical. You know, you tell them to watch out for chest pain, rapid pulse, anxiety, trouble sleeping. And there have been a few people who I wished I hadn't treated them with thyroid hormone, but nothing horrible. Somebody would call up and say, I got chest pain. I say, okay, let's get off of this. But nobody's been hospitalized or had any serious problem out of those 1,200 people.
You know, I really love your comment about thyroid receptor really being a victim of our toxic environment. On my radio show, I had Dr. Barbara Demanu, and she's a Sorbonne scientist that has made thyroid disruption by hormone altering chemicals her life career. And she had just published a book called The Toxic Cocktail, and the entire book was about how the thyroid hormone, especially in pregnant women, and then it affects the IQ and the mental capabilities of their baby as it's developing and all throughout its entire life. So that's a really great blog. If you go to my blog with Dr. Barbara Demanu, we talk in specific about how the toxic environment affects the thyroid. We have one more question here, and that someone wanted the words to your song, but one person wants to know how we can get a hold of this book. How do we get a hold of Dr. Gaby?
Oh, okay.
Medicine?
Just go to drgaby.com, doctorgaby.com, and there's an ebook version of it, and there's the print version. The print version weighs over 8 pounds. You can smash ganglion cysts with it.
I love it. And someone wants the words and music of that song. I don't think that's going to happen. And Martha says, what do you do with people who have all the signs, symptoms, and lab tests indicating low thyroid, and they have a terrible reaction every time that she's a nurse practitioner, she tries to treat it?
They get a reaction every time they try thyroid hormone. Chapter 8 in my book called Hypothyroidism goes over that. To me, intolerance to even a tiny, tiny dose of thyroid when you think somebody is hypothyroid is a clinical indicator of possible hypoadrenalism, which before I said was overdiagnosed, but it does occur. So what I always did is I give them some licorice root extract, a tincture, and that increases it prevents the breakdown of their own adrenal hormone. So it raises their adrenal hormone level, and then it either resolves the symptoms that I had thought were due to hypothyroidism, but more often it allows them to try the low-dose thyroid hormone again without getting the same side effects. So the combination of licorice root plus low-dose thyroid by some people, and it's a very small minority, but I've seen it maybe half a dozen, maybe 10 times. Those people, you put them on licorice, and then they can tolerate the low-dose thyroid. Low-dose licorice.
And thyroid are best friends, and if you treat the thyroid without treating the adrenal, if the adrenal is the problem, you can get a worse reaction because you're really not taking care of the root cause, or both things that are going wrong.
So by the way, I didn't know this was going to come up, but I have a CD called About Doctors and Folks. It's 12 original songs, and that was one verse of one of the songs you just heard. And I'll send you information on if people want to get that. I published it in 1991, and I still have 300 copies of it in the basement.
You know, I would really like a copy.
I'll send you one too.
I would really like that. Thank you so much. And I think it's our last question. Has he had success at removing the cause of the hypothyroidism from Hashimoto's, the autoimmune condition, so that patients can come off thyroid meds eventually?
Short answer is no. A lot of people talk about gluten-free diet, and there's some research on selenium, which lowers the antibody levels. But in general, what I've seen is you can lower the antibody levels, but all that means is that the gland burns out more slowly, and eventually they're going to need to go on thyroid hormone if they're not already on it. But that's not the worst thing in the world to be on thyroid hormone.
You know, it's so interesting. I've been on thyroid hormone for years, and I take, as I said, I can't handle the natural, so I take compounded T4 and T3, and I wasn't on top of getting my prescriptions renewed, and I ran out of T3 for about a week. And all of a sudden, I started getting paresthesias, tingling, bilaterally in both my legs, and all of these bizarre symptoms. And I thought to myself, that's the only difference. And I was finally able to go pick up a prescription. And when I took it, by that night, I didn't have those symptoms anymore. They were gone.
Interesting.
That was really interesting. It was black and white, like flipping a light switch. Well, this has been an incredible, we've answered all of the questions. He's going to send me a place where you can get the CD where he's got a whole bunch of songs, and that's one of the songs on there. This is a book, Nutritional Medicine, and he told you if you go to drgaby.com. Or is it Dr. Alan Gaby?
Dr. Gaby, DoctorGaby.com.
This book is really phenomenal. My gut book is going to be half of that. Half phenomenal as that? No, as phenomenal as that, but half of that. And it's really, thank you so much. You're there in New Hampshire, and you have been, what wonderful stuff. I really enjoyed it. I wish he could all hear all of us applauding. You've given of your time and you've given of your life to really create this book. And I also honor that we have such a lifelong brother and sister relationship that we have. I so appreciate it. Thank you so much, Dr. Gaby.
Well, it's been a pleasure. Thanks for having me, Lindsay.
Okay, bye-bye.
Bye.